Good morning everyone, I'll be talking about a case of bilateral neovascular glaucoma who presented quite late to us. So this was a 20-year-old male who complained of headache and severe diminution of vision in both eyes. And when we took the past history, he gave a history of vague trauma to his head around 3 months back, and for which he consulted a private practitioner. He had the previous documents and which denoted that he has a visual acuity of 618 in his right eye then, and the left eye was noted as PL absent then also. There was an MRI document also, and it showed dilatation of the optic nerve sheath and hypoplasticity of the left transverse and sigmoid sinus. And he was administered low molecular weight heparin and rivaroxaban by the practitioner there. And his personal history was normal. Family history was also normal. The general examination, his vitals were maintained. The systemic examination was normal, like he was well oriented in time, place and person, and everything was normal, all the cranial nerves were normal. In the ocular examination, what we could see was, in the right eye when he presented to us, the PL was doubtful in the right eye, earlier which was 618. And in the left eye, he was PL negative, and the IOPs were raised to the up to 50 mmHg in the right eye and 56 mmHg in the left eye. When we performed a slit lamp examination, everything was normal except that the pupil was dilated and fixed, and we could see neovascular fronts. In the right eye it was from 6 o'clock to 8 o'clock, and in the left eye it was from 12 o'clock to 2 o'clock. In the lens the cataract was present. In the fundus there was bilateral venous obstruction, the disc margins were blurred, the CV ratio was not appreciable, multiple hemorrhages were there. In the left eye the media was hazy and details was not seen. MRI was done and an NR setup, and it showed a thrombus in the superior sagittal sinus, a flattening of the posterior sclera at the optic disc with prominent bilateral perioptic CSF spaces, and a thrombus was there also in the left transverse sinus. So we suspected that whatever was there was secondary to the insult in the brain. And the patient was advised, because of the high pressures, he was advised the following, and was planned for a 270-degree cyclocryotherapy because he was having pain also. And a tablet estezolamide was advised with a topical anti-glaucoma. Post-cyclocryotherapy, the pressures went down and the patient has a little less pain in his left eye, and the congestion also reduced. So neovascular glaucoma is a sight-threatening secondary glaucoma characterized by appearance of new vessels over iris and proliferation of fibrovascular tissues in the anterior chamber angle. The main etiological factor is retinal ischemia, which leads to impaired hemostatic balance between angiogenic and anti-angiogenic factors. So high concentrations of vasogenic substances such as VEGF induce NVI and NVA that limits the outflow of aqueous humor from the anterior chamber and increases the IOP, which happened in our case. So neovascular glaucoma, if left untreated, which was in the case in our case, it progresses from secondary open angle to angle closure glaucoma, and it leads to irreversible blindness. It is an urgent ophthalmic condition, and early diagnosis and treatment are needed to preserve vision and loss. Unfortunately, the patient presented late to us, so we could not do much but relieve the pain only. So my take-home message is always have a look at the fundus in a head trauma patient, and if possible, take a fundus photograph. It can help and detect and prevent the potentially vision-threatening conditions. The patient is a young male, and unfortunately, we cannot do much about this patient. Thank you.
Thank you.
Early identification is one of the important.
The patient presented too late to us, and we wanted to give this message that he is a young patient, he is bilaterally blind, something which could be prevented at that point of time.
Now I ask Dr. Anamika Srivastava is there. Thank you.